Okay, I'm back. So, the two kinds of IV fluids that are isotonic is 0.9% sodium chloride. So it's just got a little bit of sodium chloride in it, and sodium chloride is just salt. That's all it is. It's like your table salt, sodium chloride. The other one is lactated ringers, also known as LR. Now, lactated ringers is the same thing as 0.9 normal saline. It's just got a couple of extra electrolytes in it. I think it's got a little bit of potassium and a little bit of, what's the other one? It's not magnesium. I'll look it up. It's got sodium chloride, potassium, and something else in it. But it's also isotonic. So if you're giving somebody lactated ringers, you're also not going to have a shift of solutes or fluid. They have found out, studies have shown that lactated ringers, people that need to be on IV fluids for a long time, they do better on lactated ringers because it tends to cause fewer acid-base problems. And we'll talk about acid-base in a little bit. So it tends to be a little bit more stabilizing. People that are on sodium chloride for a long time tend to start becoming a little bit more acidotic. So it's just something to keep in mind. However, now, this is what you need to keep in mind. If you add anything else to an IV bag beyond this, now you've made the fluid hypertonic, meaning more solutes than are normal. So some examples of a hypotonic solution would be 3% sodium chloride, D50, like if you've got somebody who's really, really hypoglycemic and you give them D, stands for dextrose, 50 in water, that's a lot of dextrose. If you take 0.9 normal saline and if you add like 20 milliequivalents, you guys probably can't even see this now, but if you add 20 milliequivalents of potassium, really common, a lot of people come in with low potassium, you can throw a little bit of potassium in the IV to give them a potassium boost. Well, now all of a sudden it's a hypertonic solution. And sometimes that's okay. Sometimes you want it to be hypertonic. But keep in mind, when you are infusing a hypertonic solution, what happens is because those kinds of fluids have more solutes in them, because of the process of osmosis, and everything constantly wants to get to a state of equilibrium. So what'll happen is when you are hanging a hypertonic solution, it will draw water from the cells. So you remember you've got all of these cells out here and all of the different, here's our little kidney guy. You have all of these cells, even the cells inside. If you start throwing more solutes in here, more stuff in here, because of osmosis and because equilibrium wants to occur, the water now will flow from the cells out into the intravascular spaces, and you can dehydrate your patient very quickly. So you need to be careful when you're giving a hypertonic solution that you're also monitoring that your patient is not getting dehydrated. Sometimes you want a patient to have one of these kinds of fluid because you deliberately want to dehydrate them. For example, head trauma. So if you have a patient who has head trauma and this will be like the brain up here. All of these cells are up in the brain, but the brain tissue is very swollen. You want to reduce the size of that brain, so a hypertonic solution is good. It will move water out of the cell, put it into the intravascular space, take it down to the kidneys where it can be excreted. That's a brilliant thing to do if you're trying to get your patient to have less fluid, or you deliberately want to dehydrate those cells. So the patients who are in a hypotonic state will often benefit from a little bit of a hypertonic solution. So if you have a patient like this and then you start infusing more solutes in here, like this, then what happens, because you've got more water out here, now the water is going to go into these solutes that you're adding in here because they want to get back to a state of equilibrium. So the water now is going to move out of that intravascular space and into the cells. So this a hypertonic solution is a great plan for a patient who's in a hypotonic state. Now, if you have a patient who is in a hypertonic state, and this is your dehydrated patient, your patient that has fluid volume deficits, this patient would benefit from a hypotonic IV fluid. And a hypotonic IV fluid is anything that's less than this. So your fluid that is 0.45% normal saline, sodium chloride, normal saline, that has fewer solutes. Now I've just cut my salt in half. That's fewer solutes, and so it is hypotonic. This person would do really well from a hypotonic fluid. The reason being, now I'm going to put this hypotonic fluid in here. It has less solutes, more water, and so it's going to bump this out, give us more water, and return us to a state like this. So this part is a little bit confusing. Take a little bit of time to go over and learn hypertonic, isotonic, and hypotonic conditions, and then the different kinds of IV fluids we give patients in those whatever kind of condition. And we'll go over it again. I know it's really confusing, but we'll go over it again. So start looking over some of that stuff this week, and then we'll talk about it when we get to class. Okay, so let's talk a little bit really quickly about the different electrolyte imbalances. So this starts on page 251. Here's what I want you to know about these electrolyte imbalances. I guess I don't need to change that right now. Oops. Okay, so the first one is sodium. And the thing about sodium is you can have hyponatremia or hypernatremia. Remember, 135 to 145. If you have too much, it's like this. If you have not enough, it's in this condition over here. But one of the biggest signs and symptoms for sodium is neurochanges. So if your patient has been in the hospital for a while, if they're getting certain kinds of fluids, different kinds of medication, if they have different kinds of disorders, and all of a sudden they start getting confused, irritable, lethargic, combative, those are all neurochanges, and the neurosystem is highly sensitive to sodium imbalances. So number one trigger for you to start detecting there might be something wrong with their sodium level is neurochanges. And the earlier you can detect this, the earlier you can figure it out and correct the problem. You always want to figure out what is the problem and how am I going to correct it, because you want to prevent any problems. Don't just slap band-aids on stuff. Always fix the problem. So there's a couple of things that can cause that. Syndrome of inappropriate antidiuretic hormone is a condition where you have too much antidiuretic hormone. That's this condition, because remember, your antidiuretic hormone retains fluid. The syndrome of inappropriate ADH will cause this condition, and it will cause hyponatremia. A lot of patients will use salt substitutes because salt and water go hand in hand. So a lot of people that have high blood pressure sometimes have they are on low salt diets so that they can they want the condition to be a little bit more hypertonic because it reduces the volume in the vessels, and that's good for somebody who has high blood pressure. The problem with low sodium salt substitutes, so they're not using table salts, is that a lot of those also have potassium, so you do need to be a little bit careful that while they're taking care of the sodium, they're not increasing that potassium. And the sodium, like I think we mentioned earlier, is usually regulated by thirst. You know, how thirsty you are. You could, like, okay, you know, my sodium levels are too high, and that'll trigger you to start drinking fluids. The renin-angiotensin system that I told you about. So that's what you need to know about with sodium. So kind of read up on that. The next one I wanted to mention to you guys is potassium. It goes on for a couple of pages of like how to treat hyper and hyponatremia. The potassium. Okay, now here's the deal with potassium. Potassium is the electrolyte that is really responsible for cardiac functioning. And your heart is very, very sensitive to too high and too low. It will show up in your EKGs. If it's too high, you start getting some spike T waves, some U waves in there. If it's too low, some of the T waves and the QRSs start flattening out. I know that doesn't make any sense to you, but it will in a couple weeks when we do conduction. Some of the ACE inhibitors, and ACE is that, I will show you on the angiotensin renin system. The ACE inhibitors, it comes out of the lungs and it prevents vasoconstriction. And a lot of people are on that have high blood pressure, but that can lead to potassium imbalances. The potassium is excreted through the kidneys. So again, you've got to have functioning kidneys. So you need to be careful when you're giving somebody potassium, especially people that come in and they have low potassium, less than 3.5. You need to be very careful if you're going to start giving them potassium supplements in their IV if they don't have efficient and well-working kidneys, and you'll know that by their BUN and creatinine. A lot of the medications that patients are on causes increased potassium. The things about potassium is you do watch for cardiac changes, but also other muscle problems like muscle weaknesses and things like that, because potassium is necessary for any muscle, but it's just that the cardiac ones can become lethal. So study up on the hyper and hypocalcemia. And the next one I want to talk about is calcium. Calcium starts on page 258. Normal calcium is about 8 to 10. Most of the calcium that your body has is obviously in the skeletal system and in the bones. But calcium is really, really important for nerve transmission. So it has a lot to do with the impulses that are coming out of the brain that go down all of the nerves. You need calcium to help transmit that. So one way that you can tell that your patient is hyper or hypocalcemic is they'll start nerve twitching. And there's two signs that do this. One is Chavock sign, where you can tap on their face and they kind of start twitching like that. The other one is called Trousseau's sign, where you put a blood pressure cuff on and you pump up the blood pressure cuff, and then their hand starts going like that, and because it causes tetany. So if you start doing those assessments on your patient and find out that those are occurring, you need to check their calcium, because they could be having a calcium imbalance. The parathyroid hormone controls much of the calcium release. So your patients who are going for parathyroid surgeries, or they have parathyroid abnormalities, may also have some calcium disturbances. The other thing, here's the other thing about calcium, is that it is absorbed through the GI tract in a lot of foods that we eat, like obviously the milks and the dairy products have high amounts of calcium in them. I do want you to know the foods that all of these electrolytes are contained into, because it's really important to assess what is your patient eating, and then tell them to either not eat or change up their diet, because you don't want them to have too much or not enough of something. So what was else? So the calcium, when somebody is ingesting calcium, it helps if they also have vitamin D, because vitamin D helps transport the calcium into the cells. So patients who are low in vitamin D or not getting enough vitamin D may also have low calcium levels, and you might want to increase them. And there's supplements out too. If somebody is unable to consume enough calcium and vitamin D in their diet, you might just want to put them on a calcium vitamin D supplement. The next one is on page 262, and it's magnesium. Magnesium is this little tiny cation. I don't think I mentioned it. Normal magnesium is 1.3 to 2.3, and magnesium is really good for regulating enzyme reactions. So you need that for all of the other enzyme reactions that are going on, and for neuromuscular functioning. It's very similar to potassium in that you need good magnesium so that your muscles don't develop tetany and muscle cramping. So patients who have that, check their magnesium. In the United States, alcoholics are predominantly at risk for hypomagnesium. So if your alcoholic patient comes in, check their magnesium, because that's a huge problem in the United States. Patients who have a lot of diarrhea and vomiting and stuff often drop their magnesium levels. So patients, and you might have even experienced this when you've had the flu and you've got nausea, vomiting, diarrhea for days on end, and then all of a sudden your legs start cramping up and your muscles start cramping up. It's probably because you've got low magnesium. The other thing with magnesium is it's very responsible for tendon functioning. So if you're doing deep tendon reflex testing on somebody and it's hyper or hypo reflexivity, it could be that your patient has a magnesium problem. And then finally, the phosphorus, which is on page 264. Nobody really ever talks about phosphorus, but some of these more little known electrolytes are still equally important. Phosphorus is used in muscle and tissue rebuilding. You need phosphorus to build red blood cells. Obviously, that's kind of an important one. And it also helps pull oxygen from hemoglobin. So another reason you need your phosphorus. Phosphorus is a anion. It's got a negative charge to it. It also is responsible for some of the structural support of the bones and teeth. So this one kind of goes hand in hand with calcium a little bit. It has a lot to do with acid-base balance, which we're going to talk about next. And then chloride on page 66, that's another anion. That's pretty rare to have chloride imbalances, but go ahead and read through that. So those are the major fluid and electrolyte things that you need to know. There is a lot, but this is kind of the foundation of all of the rest of the disorders that we're going to be talking about. So every single patient is going to have some fluid and electrolytes. It could be hyper or hypo or isotonic, meaning they're in a state of homeostasis, and that's our goal as nurses, is to get your patient back to a state of homeostasis. So you have to figure out what's going on with my patient, and what do I need to do to treat it or fix it. So, okay, I want you to take some time to ingest all that I just said and really wrap your head around it, because it's a lot of information. And then we're going to come back and we'll do acid-base balance, because that's equally as confusing. So sorry about that, but it's really fun stuff. You guys are really going to like this. So, okay, I'm going to go upload this video and then I'll be right back.